So my name's Jared Wohlgemut. Thanks very much for the introduction. So yeah, I'm a senior reg in general surgery in west of Scotland, which is based in Glasgow. I am Canadian, however, and I'm married to a Northern Irish woman, so my accent's a bit funny. Um, I have conducted a PhD, nearly submitted to Queen Mary University of London, working with the Centre for Trauma Sciences, and my supervisors are Professor Nigel Ty, Mr. Zane Perkins, Dr. William Marsh, and Professor Kareem Brohi. And London Air Ambulance were kind enough to allow me to work with them, alongside them with some of their data, and they're really excellent clinicians. So I'm here to share a little bit about that experience. So first, I've been funded a little bit by, well, quite a bit by the Department of Defense. That's the United States military. They funded a program of research which funded my PhD. I also had a 1-year salary support from the Royal College of Surgeons of England in partnership with Rose Trees Trust, which is a charity. I'm grateful to them. So first, I just thought it was hilarious because way back in the day, in 1947, there was this kangaroo route where you could get from Sydney to London, and it took 55 hours, or 4 days, apparently, 4-day journey. Now there's non-stop routes since 2018 with Qantas from Perth to London, and I don't know if it's already started, but there's talked about direct from Sydney to London. But here we are. I've been flabbergasted with the invitation to speak to you, so thanks very much. I'm flattered. But I'm kind of using time travel because I'm speaking to you from yesterday. So thanks very much for having me. So the first question is, in early trauma care, what are your decisions based on? So do you base your decisions on what injuries you think they have? Do you base them on whether you think they're bleeding, or some sort of overall gestalt or risk assessment, or based on your previous experiences and so on? Or is it a combination of these three? Regardless, it's still important to understand what is our base level of understanding and our base accuracy of injuries assessment and assessment for bleeding. And that's what I've been looking at for the first bit of my PhD for the last few years. So first, I've got some QR codes if you want to look these up. But I published a study last year in Scandi Journal of Trauma, focused on the diagnostic accuracy of clinical examination to identify life and limb-threatening injuries in trauma patients. Basically meant to ask, how good are we at recognizing injuries in the pre-hospital environment? It was a retrospective study, but of prospectively injured patients who were attended to by the London Air Ambulance and delivered to a major trauma centre. And it compared the injuries that the clinicians thought they had on scene and en route, and compared to the injuries they were diagnosed with in hospital. It's a fairly simple study, to be honest. There were a young cohort, 31 years median, mostly male, as many trauma units, trauma systems are, 40% penetrating, which is maybe high for Europe, but not compared to North America. The median ISS of 10, whereas 40% were severely injured, and about 8% died. And this graph is maybe a bit hard to see, but if you have a look at the paper, you'll be able to zoom right in. But on the top left is correctly diagnosed patients, and with on the y-axis, you can see life-threatening injuries of the head, thorax, abdomen, and pelvis, limb-threatening injuries of the spine, long bone, and vascular injuries, and life-threatening bleeding, both thoracic and abdominal. And you can see that basically the accuracy, those injuries correctly diagnosed, leaves a bit to be desired. Head injuries and long bone injuries are about 70% sensitive, whereas thoracic and abdominal injuries are between 50 and 70%, and life-threatening bleeding of the chest or abdomen is just under 50%. So you wonder, oh, goodness, I thought we were better than that. And then if you look at precision, it's a similar story. Missed injury in the bottom left. We are missing some pelvic injuries, some spine injuries, vascular injuries. And even, about half of thoracic and major thoracic abdominal injuries are not picked up early in trauma. Although overdiagnosis is relatively low in panel D. So we had a further look into this, and actually we conducted a systematic review and meta-analysis. It was published as a letter rather than a full article in the British Journal of Surgery last year. And we basically did a pooled estimation of accuracy in the thorax, abdomen, and pelvis. And you can see here that the pooled sensitivity of injuries to these areas are 76% to the chest, 64% to the abdomen, and 78% in the pelvis. Whereas if there's blunt injury, they're slightly worse at identifying injuries. If they're unconscious or less conscious, then it definitely severely affects the accuracy of diagnosis. And the pre-hospital setting, again, severely affects the accuracy of diagnosis. The correctly excluding injuries, or the specificity, wasn't particularly affected by these things. However, it was higher. So chest specificity was 85%, abdomen 75%, and pelvis 89, nearly 90%, rounding up. Well, okay, so we're okay at recognizing injuries. We could be better. I'll recap at the end to understand how that all fits in. But what about bleeding? Like, sure, someone might have some injuries and we missed them, but what about major bleeding? We should be able to pick that up. We're trauma clinicians, for goodness sake. Well, and I have to say, these are expert trauma clinicians that have been doing this for many, many years. And this is not really an assessment of them as it is an assessment of diagnosis in a adjunct poor environment. So how good are we at recognizing bleeding? This is a paper, and I think it's the one that Brian Burns asked me to speak on. So I'm going to focus mostly on this one. It was published earlier this year in Trauma Surgery Acute Care Open. And it actually has a fairly similar methodology with a similar cohort as well as the last paper, except instead of comparing diagnostic accuracy of injuries, but pre and post-hospital, or pre-hospital and in-hospital, it looks at the code red call or major hemorrhage protocol pre-hospital and whether or not the patient was actually bleeding. So code red, or rather, major bleeding is a significant cause of mortality. It is a preventable cause of death in trauma patients, probably the major one, if you read the literature. And there are things we can do about it. It's important to identify these major bleeding accurately, because if you overcall it, or rather, if you undercall it, it'd be a patient in front of you could potentially lose their life. And if you overcall it, it has a knock-on effect on the system. And if you call a major hemorrhage protocol for everybody, then the system will be easily overwhelmed. Well, what do we know already about this? Well, there's a landmark study called PROMPT by Wohlgemut et al. And there was actually a nested study within the PROMPT study called, or published by Palmer Inning, and it was titled Clinical Gestalt and the Prediction of Massive Transfusion After Trauma. So they conducted this study. It was a diagnostic accuracy study of whether or not the person looking after the patient in the trauma bay thought the patient would require a massive transfusion, which they defined as 10 units of red cells. And they added to that, or hemorrhagic death. So it was a fairly simple study, basic question, and it was in the in-hospital assessment after they'd done a primary survey. And their sensitivity was 65% and their specificity was 64%. And these were the ROC curves of Gestalt with the triangle compared to the TASH score, the ABC score, and the McLaughlin score. And basically they were trying to say that, clinical Gestalt is pretty good, and it's really not much better or worse than current basic scoring systems that exist in the published literature. We did a slightly different method in that we defined true major hemorrhage as people who reached the critical admission threshold. This was intentional. So the critical admission threshold is defined as people who've required 3 or more units of red cells within a 60-minute period, and other publications have extended that to any 60-minute period in the first 24 hours, which accounts for intensity of transfusion at a later time point than immediately after injury. And this protects for something called survivor bias or survivorship bias, where people who die before they can receive 10 units from hemorrhage probably would have fulfilled the massive transfusion definition if they had only lived long enough. So you're kind of terming people or categorizing patients as someone who didn't have major bleeding, even though they probably clearly did. So that's why we chose critical admission thresholds. Now, Kareem Brohi will absolutely shoot me for showing you tables, but I'm just going to show you this anyway, just to give you a flavor of what the patients were like. Similar to the last study, but the ISS, median ISS was 20. So the column major hemorrhage protocol, or MHPA, there's 142 patients for whom the code red was called, and 805 which were not. And this is basically just to show you that code red patients were significantly different in the sense that their ISS was much higher, their GCS was lower, their blood pressure was lower, their heart rate was higher, and so on. And their biochemistry and their outcomes reflect a much more unwell patient cohort. So, essentially, code red is identifying a sicker group of patients compared to those for whom code red was not called. And this is something you'd expect, but it's nice to see it in the data as well. So in the end, what is the accuracy of code red or major hemorrhage protocol pre-hospital compared to whether or not patients received 3 or more units of red cells within 60 minutes? So 97 patients were correctly diagnosed as bleeding. 45 patients were thought to have, where code red was called, but they didn't achieve the critical admission threshold. 41 patients where code red was not called, but they did receive 3 or more units of red cells, and 764 patients were correctly identified as not bleeding. So this led to an accuracy of the code red as, a sensitivity of 70% and a specificity of 94%. So actually much better than the individual injuries diagnoses or assessment. And how did that compare to the last study? Well, actually, the sensitivity was better and the specificity was much better. But they're not exactly, it's comparing apples to oranges here because one, they were assessing patients in the emergency department, not pre-hospital. So you'd actually expect their results to be worse. But two, they were aiming at 10 units of red cells, whereas we had defined it as 3. So they are slightly different studies. The other thing I'd looked at, which is probably more pronounced in the last injury study, was how uncertain, or if clinicians were uncertain in their diagnoses. And I noted this simply with any notation in the pre-hospital notes as whether or not there was an element of uncertainty. So things like a question mark, words like possible, probable, likely, unlikely, could be, which is just reality. We see patients in early after injury, and we're not entirely sure what's going on before they go through the truth circle, i.e. the CT scanner. And so there is uncertainty, and I think it's important to acknowledge it. So I tried to acknowledge it in this way, and essentially the red bars are injuries for which clinicians were uncertain. The black ones were injuries for which there was no uncertainty noted, and then the white ones are patients for which no injuries were recorded. And the one on the left were code reds, and the one on the right were not code reds. So in other words, you could expect that there would be less injuries in the non-code red cohort, which there was, but uncertainty and like the degree of uncertainty is roughly the same, both whether they call the code red or not. So even very unwell patients, they're still having a fair bit of uncertainty as to whether or not they've got an injury, and in particular vascular injury. So uncertainty is prevalent in this environment. So I next did a multiple variable regression and looked at whether or not what were the risk factors associated with missing bleeding. If we're worried about missing bleeding, what's associated with missing bleeding. You can look at the paper for how I exactly did this, but in other words, the penetrating mechanism was increased. The risk of missing bleeding increased with penetrating mechanism with an odds ratio of 2, and there's an association with abdominal injuries as well with an odds ratio of 4. And you kind of would expect this, but penetrating injury, especially penetrating injury to the abdomen, is a bit of a black box. You don't know how long the needle or the weapon was and where it went. I also looked at overdiagnosis. So what were the factors associated with overdiagnosis of bleeding? And this were things like a lower blood pressure, multiple injuries, and especially uncertainty of whether or not there was a vascular injury, vascular diagnosis. And that was an odds ratio of up to 4. And the last thing I looked at was what were the factors associated with mortality. And as you'd expect, as age increased, there was an increased odds ratio, as GCS reduced and as blood pressure reduced. But I didn't quite appreciate or anticipate that missing bleeding compared to the rest of the cohort increased the odds of mortality by a factor of 3, or by odds ratio of 3 anyway. So there's significant consequences to missing bleeding that can be shown in the data. And again, I'm just going to look at the sensitivity analysis briefly. It's hard to read, but I wanted to point out that if you separate the true positives from the false negatives, the false positives, and the true negatives with the code red diagnosis, you see an interesting pattern. And I note this in the paper under sensitivity analysis. But basically, there's kind of like this gradient of patients whereby their degree of penetrating injury, their injury severity score, their GCS, and their blood pressure kind of goes from one to the other. The true positives are the clearly unwell patients. The true negatives are the clearly well patients, but these ones in the middle are more borderline. And actually, interestingly, so the false positives, the ones that they thought had bleeding but weren't, they have actually a lower blood pressure or median than the false negatives. So we're missing bleeding for patients who actually have reasonably normal blood pressures, but we're calling code reds on patients who are hypotensive, but it must be for another reason. And that's not to say that there's loads and loads of bleeding mimics. I think that there aren't many, but physiology can sometimes be misleading. And again, quite interestingly, the biochemistry and the outcome of patients is again really clearly demarcated in our paper between true positives, false negatives, false positives, and true negatives, between very unwell patients here, very well patients here, and kind of borderline in the middle. So just to recap, clinical examination, I think, has poor sensitivity but high specificity for major injuries. And there are slightly more missed injuries than those which are overdiagnosed in the pre-hospital environment. Clinical examination has a moderate sensitivity and a high specificity for major bleeding, which actually leads to a similar overall number of those patients who were missing their bleeding to the number of patients who were overdiagnosing bleeding. So the absolute number is almost the same. I think it was 45 and 41. And I found that uncertainty is extremely common, especially in torso and vascular injuries, and that uncertainty itself worsens the accuracy of clinical examination, often leading to overcalling injuries. Based on the logistical regression analyses, missed bleeding was associated with penetrating mechanism and abdominal injuries. The overdiagnosis of bleeding was associated with hypotension, polytrauma, and uncertainty, specifically about vascular injuries. And mortality was associated with an increasing age, a reduced GCS, hypotension, and missed bleeding. So I think there's lots and lots of discussion points, and I'm happy to answer questions so we can have a discussion. But I think as clinicians, we should probably be using a broader estimation of risk of hemorrhage rather than relying solely on clinical examination or basing it on just a few factors. There is an apparent need for diagnostic adjuncts and decision support in trauma. I think this has become more and more clear in my head as I've conducted these studies and read around the literature, and as I've formulated the arguments for the rest of my PhD, which is essentially on decision support. And pre-hospital decision making, I think, it's not inadequately understood and studied. It's more, there could be a lot more we can know about pre-hospital decision making. I've been really fortunate to attend some of the London Air Ambulance clinical days, and the debriefs. They have 2 a week, and they're really excellent. They really focus in and hone in on decision making aspects and why we make decisions with the information that's available to us at the time. It's something that surgical M&Ms and could learn a lot about, a lot from the air ambulance services, I think. So in the future, I think diagnostic adjuncts are going to become more and more important in trauma, especially if they can improve our sensitivity and reduce our uncertainty. And there's other outcomes as well we could measure, such as improving our decision confidence, and obviously patient outcomes, but those are a little bit harder to come by and downstream. But just a reiteration that pre-hospital decision making is certainly complex, and we make decisions under a lot of uncertainty. So I really appreciate the fact that you've invited me to speak, and if you have any questions at all, feel free to email me. If you want to follow me on Twitter or X or whatever, that's my details. And these are some more QR codes for the papers that I've presented here. Yeah, look forward to any questions.
Thanks, Jared. That's really interesting research and very relevant to us. Any questions from the room?
Huge thanks for that. It's really good to see study done on the decision making that we do in pre-hospital world. It's kind of not really well covered in the literature. From our services experience, our big challenge is distinguishing vasoactive head injuries from bleeding patients. So that's been our major challenge. We see lots of blunt trauma, very little penetrating, but the patients that make us look silly is the patient that ends up having a severely damaged brain but no bleeding, and we're administering blood products too because their blood pressure is 70 systolic. Is that kind of the group of patients they're seeing in London as well?
So I'm going to give you a full disclosure. I am not a HEMS doctor. I have not worked pre-hospital, but I have attended a lot of their debriefs. I've conducted 2 qualitative studies where the participants were, one was purely HEMS doctors, and the other one, about half of them were. So I feel like an outsider that understands what you're talking about. Yeah, there is a constant discussion. I think it's fair to say. I don't know how many people from LA are plugged into this call. Their research lead, called Dr. Flora Bird, was going to send it out. But I think there have been discussions, and certainly a back and forth between so-called bleeding mimics and major hemorrhage patients. It's kind of a perennial problem, I believe. And certainly I see it once they get to the emergency department, and that's when responsibility turns over to in-hospital clinicians like me and others. It's still a difficult thing. I guess I think about it from a consequence point of view. If you miss major bleeding, like this study shows, you could really have major consequences. What is the consequence of giving 1 or 2 units of blood to someone who's got a head injury? I don't know if there's massively negative consequences or not. Obviously, you want to focus on secondary prevention of oxygenating the brain and whatnot. But I don't know if and also the other thing to know, especially in blunt injuries, you can have both. So it could well be that they're hypotensive because of both a major head injury and a massive bleeding, which may or may not be occult. So yeah, I think these are difficult decisions, and even more so, and more reason to have overall risks to make these decisions rather than an individual examination of the chest or the abdomen, which may not be particularly accurate. I don't know how you feel about that answer, but yeah, we have a system in London where you've got both code red and code black. So code black for the severe head injuries, and code red are patients who you suspect are having major bleeding. And there's been many patients who are both. They come in as a code red and code black because they are having, potential coning as well as occult bleeding from somewhere. So yeah, it's a great question.
Yeah, thanks for that. The only other thing I was going to raise was the use of ultrasound. So ultrasound is something we feel strongly is helpful, but in no ways excludes injury. But I know London has come from a different perspective, when I worked for them 15 years ago, they were very unkeen on using ultrasound and have sort of moved to using more ultrasound. How many of these patients were getting ultrasounds? That's my kind of question.
Yeah, that's a great question. And in some ways, I'm glad you asked it, because they were not using ultrasound at the time of the study. So there's no ultrasound in the pre-hospital space in the 2-year cohort that this study represents, which in some ways makes it even better as a diagnostic accuracy study of clinical examination alone. There's very few diagnostic adjuncts that were able to contaminate the results of the study, if you like. But now they are using pre-hospital ultrasound. They have introduced it with a fair bit of enthusiasm since the study cohort completed. So yeah, another great question. And there are, like anything, and again, this came out in my qualitative studies, which I'm not presenting today, but there are some people who are more excited about it than others, and there are some circumstances which definitely call for it. Whereas some, leg bleeding, for example, something from the common femoral, it's not really relevant. But yeah, it's definitely now on all the equipment. It is a key piece of equipment that goes with all the services in London Air Ambulance.
That's fantastic. Thank you so much, Jared. Thank you for joining us, especially since you had to navigate the complexities of time travel and teams and all of that. So we're very grateful for you being here. We might move on because we're up to our next session now, if that's okay. But as you said, anybody has any questions, I'm happy to share your email address and we can get in touch with you.
Yeah, thank you so much. I might leave at some point to go to bed, but thank you so much for having me. Appreciate it.